Hello, my name is Dr. Chris Magryta, and I'm here today to sit down and give a discussion on asthma. In particular, in this case, I would like to look at asthma from an upstream perspective. Why do we have these problems with kids and adults with asthma? What are the upstream levers we can pull on? And frankly, are there things we can do that isn't being done currently in modern medicine that is, in essence, going to change the narrative of how children move forward in the healthcare system? The thought process around asthma really revolves around, asthma history, right? So asthma is an ancient Greek word, and it actually means being short of breath, or in other words, to pant. So Henry Salter in the 19th century said that asthma is a paroxysmal dyspnea of a peculiar character with intervals of healthy respiration between attacks. Paul Ehrlich noted eosinophils and mast cells in pathological lung tissue upon microscopic examination. And then Dr. Prosnitz in 1921 discovered a protein antibody called IgE that was thought to be the main mediator of disease. And now we know that there are multiple endotypes and immunological cytokine pathways that mediate this disease that we call asthma. If we define asthma as it is defined today, it's called a heterogeneous disease, usually characterized by chronic airway inflammation, defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time in intensity, together with variable expiratory airflow limitations. If we want to predict asthma, there are ways now to do this in our modern society. There's something called the Asthma Predictive Index, and we can use this at roughly 3 years of age in kids. The major criteria are genetic or epigenetic risk of paternal history or parental history of asthma and or eczema. Minor criteria include eosinophilia on a CBC, wheezing without colds, and allergic rhinitis. Clinical criteria could be more than 4 episodes of wheezing and sensitization to air allergens or foods such as milk, egg, and peanut. Those all constitute minor criteria. And then there's a great work by Dr. Fernando Martinez, the University of Arizona, where he looked at kids under the age of 3 and said, why are some of these young kids wheezing, but they don't actually go on to develop asthma? And what it turned out was that they had small residual lung capacity, so those smaller airways caused them to wheeze when they had viruses because the mucus development. But those kids did not go on inevitably to develop problems with breathing that we call asthma or reactive airways disease of the aging kids. Then there was a second group that was over 3 years of age that wheezed but didn't have a super strong atopic history, and those kids eventually outgrew it. And there's the later onset group that was atopic, IgE mediated, and those kids tend to go on to having asthma in their later years. So again, if we want to find out why this disease is coming to pass so much now as opposed to in the past, we have to start thinking about what has changed in the exposome or the world outside that might be driving this disorder that we see today to be so clinically relevant and so clinically frequent. What are the possible etiologies? And for that, we really have to go back upstream. I tend to like to think of this from an anthropologic perspective. What were we doing thousands of years ago that we're not doing now, or hundreds of years ago even, that was beneficially protective from an immunological standpoint or epigenetic standpoint, but now things are different. Something's changed. What has changed? Well, we have to start thinking about this from the perspective of who's done some research here. Well, there's a really good paper we're going to talk about called the Stein paper, or Dr. Stein did this with a comparison of the Amish and Glutarite enclaves or communities in the United States where they're genocentric populations, but they had differential outcomes. Jean-François Bach wrote a great paper in New England Journal of Medicine looking at what happened when Germany unified, right? So East and West Germany. That was a fascinating piece. And they looked at that and found out that East Germany, they thought, would have much higher rates of asthma because it was industrially much more polluted and it was more impoverished. So they thought that would be much higher risk of asthma. Well, it turned out to be the exact opposite. West Germany, which was cleaner, had less exposure to bacteria and parasites, actually turned out to have more asthma disease than its East German counterpart. Then Joel Weinstock did some work looking at what happens when we get exposed to different parasites and disease, not specifically asthma in this case, but other diseases of this nature, right? And how parasites are involved in IgE-mediated inflammation for the body to rid itself of the parasite. So there's something going on there potentially. And then Dr. William Parker at NC State had been doing some work as well. And so there's a lot to be said here. Is it the bacterial exposure? Is it the parasitic exposure? Is it the chemical exposure, or all of the above? So let's look specifically at the Dr. Stein paper titled Innate Immunity and Asthma Risk in Amish and Glutarite Farm Children. And I thought this paper was really emblematic of what we need to think about when it comes to the world of asthma and allergies. So the two enclaves are relatively similar in the sense that they're genocentric, and they tend to maintain their genetic population through reproduction within the communities. So in that sense, It wouldn't be a genetic variant that makes the big difference in this case. And so they looked and said, okay, well, what's going on? Well, the Hutterite community is farming, but the difference is the farms are peripheral. The fathers tend to go inside this farming community to do the work, and the homes are on the outside, children and mothers are on the outside, and so that's the difference. Amish communities, those are single-family farms, all clustered in a large community, but the animals, the families, the father, everybody's living on the farm and they're working it together. So that was the primary difference. Then they measured the endotoxin level, which is the bacteria that are present in the dust of those homes. And they found that in the Hutterite homes, there was much less endotoxin than in the Amish home. And then they took and looked at mice that are known to develop asthma, and they exposed them to the dust and found out that, oh, by the way, these baby mice that were exposed to the dust, the Hutterite endotoxin exposure caused a certainly large differential in asthma incidence than the group that was coming from the Amish community, positing that, yet again, it's the endotoxin exposure that's driving the disease. Because when they went and looked at the two communities, they found out that, oh, by the way, the children of the Amish communities had less asthma and allergies than the children of the Hutterite communities. So the follow-up with the translational model with the animal study just sort of reinforces this. So we know there's something going on epigenetically when it comes to bacterial endotoxin exposure. Is it microbial exposure? That wasn't studied, but Dr. William Parker told me he thinks that might be a big piece of the pie too. Can't answer that, but we certainly know that microbes are associated. We know this is true in autoimmunity now. We know this is true in atopic diseases in general. They're all tied to microbial, intestinal microflora. Translational research continues to demonstrate this, that mice bred in germ-free environments are more predisposed to autoimmunity and allergic type phenotypic diseases. Exposing those same animals to microbes early in their life is shown to be preventative in this. So, there's something to be said here. What about delayed gut microbiota maturation in the first year of life as a hallmark of pediatric allergic disease? Nature Communications recently published in 2023 a piece looking at this exact story. And as it turns out, if the microbiota are delayed in getting to where they're supposed to, based on a population analysis, those people are at higher risk for pediatric allergic disease. Why would that happen? Well, there's a lot of things that can go sideways that could make that happen. Ultimately, some of the most important ones that promote tolerance, we think of vaginal delivery versus C-section. Turns out vaginal delivery is more promoting of the evolution of the gut microbiota. Breastfeeding versus formula feeding. Breastfeeding enhances the microbiota better. Primarily, this is due to many different things, but one of them being human milk oligosaccharides, of which there are 220 plus in the breast milk, but only 3 have now been added to formula in general. Some are up to 5 now. Avoidance of antibiotics and antacids turns out to be a main player in promoting the evolution of the gut microbiota. So in converse, the folks that get exposed to antibiotics or exposed to antacids are at risk for delayed maturation. Well, this could also be a function of mom's microbiota was dysfunctional from the beginning, which puts that at risk right out of the get-go. So that's something to pay attention to. And then diet. Maternal diet may have a big play in this. Oh, and so, by the way, does the child's diet, right? And then another player could be maternal infections or childhood infections. So there's a lot of things that come into the exposome of the child's life, the exposures that they have, that's going to drive tolerance one way or the other. But we really like to look at tolerance as a main way of saying, what's really going on here? And are we getting to where we need to get to? What about microbial transfer at birth? I thought this was super fascinating. A recent study just published looked at microbial transfers and found that, if you did vaginal microbial transplants, there was significantly altered gut microbiota maturation and regulated levels of certain fetal metabolites and metabolic functions that were in line with better health. So C-section rate was 1970, roughly 6%. Now it's in 2020, roughly 32%. So that would be therefore another net negative as we look at this. And so maybe we should be talking about fecal microbial transplants as a way to potentially get the microbe evolving appropriately. And then biodiversity. This is a big play, right? So rainforests, areas of the world where we see ecosystems very diverse, they're prone to having less problems. You think of the rainforest of the jungles of, let's say, South America. When the species are differential, there's competition and growth and everything moves in the correct direction. We can think about this farming, right? So when we clear cut a field and plant only corn for a while, eventually pests come in and start to destroy the corn, so they need pesticides. But if you plant diverse species there together, they sort of cohabitate and they work together to keep pests at bay. Same thing's going on in the microbiome of the gut, lungs, everywhere. Microbial diversity is less associated with disease. Biodiversity in a positive manner is not associated with our best health. I would say at this point, it's a good time to switch into the understanding of epigenetics. So Dr. Randy Journal did some amazing work. In the early 2000s, he did the seminal research paper that looked at this mouse called the agouti mouse. So the study was really elegant. He said, okay, what happens if we take the mom agouti mouse and the dad agouti mouse and put them together? Well, in general, they're always going to produce a mouse that is yellow, prone to obesity, prone to diabetes, and prone to cancer. Well, his postdoctoral fellow at the time was Dr. Robert Waterland, who came from a nutritional background and said, what if we give certain foods that are known to be methyl donors, right? So carbon atom with 3 hydrogens on it, and said, what happens if we put this into the food of the animal while they're pregnant? Lo and behold, it turned out that the babies came out brown, skinny, non-diabetic, and non-prone to cancer. This was revolutionary. Then when they looked at the DNA, they found out that there were lollipops of those methyl donors stuck on the upstream regions of the CPG islands of the coding segment. So it said to the gene, silence, don't read the agouti gene, outcome of the child is different. So it was this first time in life we realized that Jean-Baptiste Lamarck was correct and Darwin was incomplete. He's not incorrect, he's just incomplete. And it's that this epigenetic phenomenon that in your lifetime, something could change that allows the genes to be read differentially that leads to a different phenotypic outcome. And in this case, the mouse went from being prone to having a yellow coat color, obesity, diabetes, and prone to cancer to not. That would have been great where it ended, but their lab went on even farther. And this is where it got even super fascinating. So we have the plus of the benefit of the methyl donors, in this case, the food given to the pregnant mom. And then what happens if we do something else? So his next postdoctoral fellow, Dr. Dana Dolanois, came from a toxicology background. And they said, what happens if we give BPA, a known hypomethylator? So it does the opposite of the methyl donating foods. So BPA is the plasticizer used to make plastics hard. It's been in all kinds of things. Unfortunately, it was in baby bottles when we were in the early 2000s and late 1990s, dysfunctionally so, but I don't think anyone knew. Maybe they did. Ultimately, when they gave the methyl donors and the BPA to the pregnant dams, they ended up, once you got to a threshold where the methyl donor was hypomethylated more because the access to the BPA was higher, the animals came out yellow, prone to cancer, diabetic, and obese. So you got to pause there and think, this is massive. So here's the time where we're sitting here saying, we do have control. This is hope. This is destiny. This is the availability to say, wow, food good in this case, toxin bad in this case. Not to always say it's always that way, but in this case it was. So now we have to open the door when we think about asthma. Is epigenetic modification part of this? And what are the places that epigenetics could play a role in this? Well, maternal metabolism, certainly a piece of this. We know that. Maternal toxin exposure, certainly a piece. Infections playing a role. Imprinted genes, the imprintome. Dr. Journal has written recent papers on that. Placental dysfunction, maternal nutrition, clear. Oxidative stress, probable in most cases. And so we're starting to see a sort of a collation of information that says we have more control over outcome than we think. What are the levers that we can pull on? For me, it's all about immunology, all about inflammation, all about epigenetics. So the levers to me are all related to that. Nutrition, right? Helping the microbiome out of the gut, feed the gut, really important. Help to keep inflammation down, right? Avoidance of toxins, right? There's all of these things that are super important. But at the end, the bottom line is it's immunology fundamentals are the keys to opening the window of reversing these disease onset processes. And that goes back ultimately to what Dr. Jeffrey Bland calls the exposome or the environmental exposome. The environment can be anything, right? This could be stress, food, chemicals, weather, temperature, you name it, right? So, but these are triggers. These are antecedents. These are things that can set the ball in motion in the wrong direction. And then they will trigger in the body, potentially the enteric nervous system, right? Right? That's a possibility. But more importantly, when you think about immunologically, we talk about, hey, maybe we're triggering pathogen-associated molecular patterns or damage-associated molecular patterns like toll-like receptors or nod-like receptors. Maybe we're triggering the immune system that then is training local immune cells like NK cells, MAX, epithelial cells, fibroblasts. Maybe they're getting trained or brought to the area to cause disease, right? Then the dendritic cell comes in and says, hey, let me migrate over here and teach other groups what to do. Now, the naive T cell gets educated. Maybe that education is Th2 polarization. Maybe that education is against DNOT. Maybe that education is against some part of a tree. Oh, by the way, now we're starting to see a pattern of immunologic development of broken tolerance against ourselves. Instead, what we want to see is tolerance. We want to see development of normalcy. We don't want to see the body react in any way, shape, or form to the outside environment of the exposome negatively. We want it to react to pathogens, things it's supposed to fight. So all in that process, we need to start thinking about T regulator cell function in particular, right? So how do we develop tolerance? Well, we want to keep T regulator cell function in play, right? Because T regs have incredible functions. If you look at the slide, we're seeing here Tregs block overactivity of mast cells, eosinophils, basophils, ILC2, NK cells, natural killer T cells, B regulator B cells, B reg cells, right? Th17, Th2, Th1. There's this incredible governing system. I liken this to military police. If you think about going to let's say a war, and the war is in stand down mode, right? And guys are sort of hanging out. There's not much going on. The ladies and the men are there, and there's nothing really happening from a fight perspective. So that's in general where fights break out, problems break out. You think about the old movies where they're at the bar drinking, partying, and you need the military police to come in and keep everything in order, right? Before the war ramps up again or whatever's going on ramps up. Well, the immune system, somewhat similar to that. And the military police to keep order are the regulator cells, the Treg cells, right? So we care a lot about this. Well, what do we know about Treg cells? How do they stay in balance? Well, if you look at a paper from Cell Reports by Dr. Tan, it was entitled Dietary Fiber and Bacterial Short-Chain Fatty Acid Enhance Oral Tolerance and Protect Against Food Allergy Through Diverse Cellular Pathways. And what really came down when they looked at it was that vitamin D, vitamin A, and fiber were the big keys to adequate T regulator cell development. So that tells us very clearly that the immune system's involved, but oh, by the way, so is the microbiome. That's important, right? And if you put those in adequately, it was very well shown that you have increased Tregs, Treg function, and secretory IgA, which is found in the mucus to protect yet again, against pathogens, right? So that's important. So we want tolerance. So we're looking for ways to develop that natural B-reg, Treg, the regulator cell activity. Huge, huge stuff. When we look at asthma, it's in general, it's slanted towards a Th2 skewed type, but that's not entirely true, right? In the New England Journal of Medicine, they looked at major endotypes that define the pattern of immunologic activity. And we know now that there's a Th2 high asthma and a Th2 low asthma. Th2 high asthma sort of differentiating these two types where one is sort of the allergic response with massive amounts of eosinophils and this infiltration, and you get triggering of the dendritic cells, which then comes down and teaches the T cell what to do, which then turns the mast cells on, and you're off to the races with IgE-mediated production, and boom, 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 right? In the eosinophilic asthma, you get the triggering again, but this time it's through TSLP, right? Tissue-specific lymphoprotein, right? That then triggers ILC2, which then goes down and again triggers this massive eosinophilic event, mast cells, basophils, and massive release of the things that what we see is the wheezing and all the symptoms that are based on that. And then the Th2 low asthma is a very different system where it's more neutrophil based with macrophages, and the neutrophils develop neutrophil extracellular traps, which are sort of like these swords of DNA that come out in between a neutrophil that kills pathogens in between it. That's a very tricky one. And that's a much smaller subset, but it's a really important subset and tends to be more associated with obesity. So in the Th2 high group, we're really looking at why is this getting turned on, right? So again, if we go back upstream, we're thinking something went wrong in the priming stage, the tolerance stage, and now we're starting to react to allergens. Now we're starting to react to things in the environment that are triggering. Or you look at the other side of the coin where it's a non-allergic phenotype where you have pollutants, microbes, glycolipids, different things that we're getting exposed to that are triggering it. So we could say, okay, we know the antecedent reasons as to why this is going sideways are more related to things of early birth in utero and then soon after birth. But then as we get older, we have to start saying, okay, well, other things are tipping the immune system into trouble now too. So the avoidance of allergens is important if they're triggers. The avoidance of toxins that are mediating disease, trying to maintain the good microbiome of the lungs, stuff we're just starting to beginning to understand. So the immunology is becoming super important because we know now based on the differential endotypes that we need to start looking at these patients a little bit differently. And I think this is where social determinants of need is going to start coming out so we can start getting into the homes of these kids to see what potentially are these triggers. If we got into the home of a child and see that there's a cigarette smoke going on there, there's vaping, there's Glade plug-in, some chemical structure, they had recent renovations, we could differentially look at this in a better way to pull those triggers out, to let the immune system calm down so we don't need as much steroids. Because the problem is, again, we sort of tend to treat just with the drugs in a lot of cases, and that's not ideal. Upstream is better. Let's get farther back towards the beginning to try and really change the outcome for these kids. We know there's a lot of different cells involved in this, so there's multiple pathways to look at this. So, we have Th1 can be involved, Th2 primarily, Th9 can get involved with mucus development, Th17 can get involved, especially with the neutrophil piece. And so we have to pay attention to all lines of this. Sensitization is becoming a big piece now too, right? So we talked earlier, Martinez's work, if you're sensitized, and, if you're looking at asthma type, sensitization is going to make a big difference in the outcome because if you are sensitized, that usually means that you are tolerance broken and going to go off to the races for a long period of time. So we want to really try and prevent sensitization. One of the biggest reasons I think we're getting oversensitized now is milk protein intolerance, right? So kids who are born at birth, these days, for some reason, are tripping into milk protein intolerance at really high rates. And by that, I mean casein protein sensitivity, not allergy in most cases. There are some cases where it's actually cow's milk allergy or casein allergy, but in a lot of cases, just cow's milk protein intolerance. So we don't truly understand the immunology of it, but we do know that we switch these kids to hydrolyzed formulas, their eczema gets better and the diseases sort of fade away. And for me, when I think about it from the gut perspective, I think we're really getting into where that inflammation is occurring in the gut repetitively over and over again. If they're still exposed to the milk, that then could lead to downstream leaky gut, which then is allowing more permeability to different pathogens and different food types or proteins that leads to other immunologic irritations, or in this case, food sensitivities or food intolerances, or frank food allergies, depending on which part of your immune system that gets turned on. We know these things are on the rise, right? True food allergies on the rise, right? We have now sesame as a 9th food allergen. So this is a ongoing problem, this food allergy march. I recently spoke to Dr. John Warner about this, and it's very clear that a lot of the things that we talked about sort of in the beginning with this microbial development, this tolerance development, is at the root of all of these problems, right? So we really want to start trying to catch this early, but in the absence of that, really work hard on trying to understand what can we do in the short run, right? In a lot of cases, it's avoidance of the trigger food, right? Intestinal inflammation and permeability is a loop. It is a loop effect that'll cause trouble. That is something we don't want to see happen, right? I really worry a bit about COVID-19, what happened during that period of time where we're really sterilizing the environment way too much. I think it's probably going to turn out to be dysfunctionally problematic for these kids that they had super clean environment, not enough exposure to things that were of the microbial nature that help force tolerance. So I'm worried we're going to see more and more allergic and atopic and autoimmune type diseases coming up. Ultimately, we have to think about this again from a tolerance development perspective. Pathogen comes in, toll-like receptor receives, part of tissue goes into the macrophage, education of a local T cell, that can then takes via dendritic cell over to our either our thymus or our local lymph nodes. You have education in that area, you get antigenic epitope spread, and now we have normal tolerance. This is the way it should be. Clonal energy will occur if the protein or the antigen that is exposed to is supposed to be something we don't react to. The body will not make T cells that are active. It'll go into this what's called energy phase, and we'll be in good shape. In the abnormal state, that doesn't happen, and for some reason, the body persists in developing this pattern of antibody and T cell response, so B cell, T cell response to whatever that protein structure is. If it happens to be pollen, you know what happens there. But it's all going through this educational system that we consider to be pretty normal. So what is primary prevention again? So if you look at the slide on sensitization, I think this is super fascinating. You know, what can we do? Well, primary prevention is, at this point, mostly avoidance of the trigger, right? And there's a lot of controversy here because if you look at the data from the LEAP study, you know, there was don't avoid foods while pregnant, clearly, and then don't avoid foods for the whole time, right? So there was this really important window of time where if you gave the child the food before 4 months or after 12 months, they were at higher risk of developing food allergy. But in this critical window of 4 to 12 months, which happens to be anthropologically when kids start putting food in their mouth, that's the priming window. But unfortunately, if they're reacting to the cow milk, we don't have much option to wait till 4 months while they're completely eczematous with green stools and bloody diarrhea, they're colicky. So we have to pull that out. And then hopefully they get microexposures over time that helps train their immune system to be resilient and tolerant over time. But in general, we want to expose kids to all foods between 4 and 12 months of age. I think that's pretty clear at this point now. That's what we should be doing. Let's shift gears a little bit. What about macronutrients? How are they affecting the asthma allergy frame, right? So for me, everything has to go down to what do we know? It's really hard to study nutrition, really, really hard. We don't have much in the way of great studies that help us say this food, that food, this food, that food. We have some, and we'll get into some of that, but in general, it's this global picture of what foods are really problematical. And a simple way of saying it, ultra-processed food is a major problem. Dr. Robert Lustig and I had a long conversation about this, and ultimately, that's the big player, right? You can eat a diet from Southeast Asia, from South America, from Europe, from South Africa, and in general, everyone's okay until you bring in these processed foods. Well, what do we know? We do know that bariatric surgery is incredibly powerful at reducing inflammation and reducing the metabolic parameters that drive asthma and obesity and metabolic diseases. So folks that had a bypass surgery dramatically did better with asthma post-bariatric surgery. So that is a direct effect. Food in, now you can't get as much, now you have less disease. Now there was one caveat, there were failure groups, and in general, those were folks that were really far down the metabolic syndrome pathway. So even by fixing the gut via the stapling and the bypass, you were unable to completely ameliorate. But in most cases, it did ameliorate the disease. So we know food's a big piece of this. Rick Johnson's work, I think, is super important, right? Rick Johnson He wrote the book, Nature Wants Us to Be Fat. And what he did was he really looked specifically at fructose and how fructose is driving the metabolic parameters that lead to fatty liver, high blood pressure, foraging behaviors of eating more, and also fat deposition of the periphery, and then the immunologic parameters that follow after that. And then the big problem we know is that fructose ingestion has gone through the roof in recent past, right? 2008, from a study with Voss et al., they noted that the consumption of fructose in children was estimated to be 55 grams per day, or 10.2% of the total caloric intake. Highest among adolescents at 73 grams a day, which is 12.1% of calories. So, problem, and we'll get into the why. Well, the terminal byproduct of fructose metabolism turns out to be something called uric acid. And uric acid is an unbelievably potent trigger of inflammasome activation. Inflammasomes is part of the innate immune system, a fireball, pyrin, that comes up and causes inflammation in the local area. So if you have uric acid of high volume flooding the liver, you can get a lot of inflammation in the liver, right? So this is the big piece. And he showed this with hypoxic placenta, that if you have a mother consuming excess fructose, there's delayed placentation, which causes endothelial damage and is causing increased uric acid deposition, which then is leading to secondary problems that we see in preeclampsia. And I won't get into the details there, but his study is fantastic looking at that as well. So we know now from the research that fructose, when it's metabolized, it clicks on adenosine deaminase, which then turns it into adenosine. It turns ATP into AMP, eventually to IMP, which then eventually goes to inosine, hypoxanthine, xanthine, and eventually uric acid by xanthine oxidase. And again, uric acid is so important because it turns on inflammasomes, right? And that really matters because in the end, we're going to be looking at lots and lots of reactive oxygen species, lots and lots of triggering of the innate immune system through PAMP and DAMP recognition, and then you're off to the races again. So this is a big deal. Secondarily, now you can look at it from the glucose perspective. So let's talk about that nutrient, right? So sugar is a disaccharide of glucose and fructose, about 50-50. High fructose corn syrup just increases the ratio of or percentage of fructose to glucose, and they're metabolized very differently, right? So fructose is metabolized, it's phosphorylated, but there's no negative feedback loop. So once you start metabolizing fructose, it drops the phosphate level inside the cell, which is an alarm signal, which turns on this whole host of events that leads to the problems that we see in the liver that we stated, which was fat deposition, which is high blood pressure, which is peripheral fat deposition, and foraging behaviors. This was a fantastic thing back thousands of years ago when food may not be easy to find. So you'd want to suck down all the fruit you could, turn the fructose into fat for storage for a rainy day. Not so much now. How about glucose? Glucose comes in a polymer as a starch, could be stored as glycogen. So in the muscle of an animal, you could have it as glycogen, but primarily glucose comes as starch from plant fibers, right? Well, what happens when you break down the glucose? Well, it's phosphorylated again and goes via hexokinase into the Krebs cycle and you're making ATP. Oh, but by the way, it could be reverse engineered through aldose reductase into sorbitol. Sorbitol then could be turned back into fructose. So we have a secondary pathway to make more fructose, and then fructose would then go down the pathway again to uric acid in high volume. So you can start to see how dietarily we have mechanisms of understanding how fruit sugar or table sugar or honey or any type of sugar that's out there, high fructose corn syrup, has the ability in high volume, especially if it's consumed as a beverage because you don't have that protection of the fiber to slow digestion, hits the liver super fast, and you have these issues. And this is even bringing into effect advanced glycated end products, which are sugar and proteins cross-link, which grabs receptors called RAGEs, that turns on reactive oxygen species, mitochondrial damage. And in the end, everything really results in mitochondrial damage. The powerhouse of every cell, if it happens to be in your lungs, happens to be in your skin, happens to be in your gut, you're going to have problems like asthma, eczema, irritable bowel syndrome, and all those other problems. What are the levers you can pull on for this? Well, fasting, clearly you avoid the foods that cause the trouble. Exercise, massive benefit because you turn on GLUT4 receptors, which are independent of insulin, so you shove the sugar right into your muscles to burn it so it doesn't end up getting to your liver. Great thing, right? So there's herbs like berberine, which are beneficial in this case. Curcumin, known to block NF-kappa B and block STAT3, and there's a lot of stuff that's related there. We're not getting into the gory details of that now, but there's ways that we can start looking at going against this macronutrient slug. And then, of course, we could talk about vitamin D, vitamin A, and fiber for helping the Tregs do their job. But ultimately, the biggest piece is avoiding the trigger foods, the ultra-processed foods. Fasting is a great idea at the correct ages. Exercise is super important. And then potentially start thinking about herbs like berberine and stuff. The inflammasome, again, I think is one of those discussion points we probably need to hammer home. The NLRP3 inflammasome is something that gets triggered by damage-associated molecular patterns or pathogen-associated molecular patterns, right? And if it's triggered and it turns on, Great, you got something to kill, pathogen. But oh, by the way, if it's triggered by uric acid, this isn't good. And if you can see by the slide here, caspase 1 turns on, and that's all triggered by this whole cascade of events. But it can also be triggered by lipopolysaccharide. So we got uric acid on one hand, directly coming from fructose, that macronutrient. But oh, by the way, you could have lipopolysaccharide. That's a fat sugar molecule of a gram-negative rod that those bacteria grow in our gut based on ultra-processed food again. So the more ultra-processed food, again, you're consuming, you're producing more gram-negative rods in your gut, dysbiosis. Then you get leakage of those gram-negative rods. Byproducts is lipopolysaccharide, which is well known through Patrice Conni's work as systemic endotoxemia. That gets into the bloodstream, gets grabbed by a toll-like receptor. That can trigger the inflammasomes. It can also get grabbed. It can also be taken up by LDL or HDL particles, brought back to the liver. There's a lot of stuff going on here, but ultimately we care about it from the inflammasome perspective. If it's triggering inflammasomes, it's triggering inflammation. So uric acid and LPS, two big players driven by macronutrients, food. We care a lot about this. So the other big thing I thought was super interesting is RSV. Found out that RSV, respiratory syncytial virus, is a known trigger of asthma in kids with genetic predisposition, right? Uric acid is also involved in that. And when they inhibited xanthine oxidase activity, they were able to slow down the development of asthma phenotype in somebody exposed to RSV. So inflammasomes are at the center of this whole asthma story. And we'll see how much it becomes the main piece of it over time. But right now, it's a big piece for me. And in my clinic, I see this. When we get kids' diets fixed, we pull out these sugars, ultra-processed foods, we see resolution. We see downregulation. If they're in moderate, severe land, we bring them down to mild land. Less disease, less need to be in the hospital, less need to be in the ER, less need for high-dose medicine. So macronutrients, for me, we don't have great analysis in single studies, but we have really good analysis and mechanistic understandings and sort of this what I would call epidemiologic analysis of the types of diets that are more beneficial. What about cofactors, right? So we've talked about cofactors in the past. Cofactors are super fascinating in the sense that they are minerals and vitamins that are involved in enzymatic reactions, right? And so they're necessary for all systems of biology to work. At an immune sufficiency state, you want them there. Calorie-rich, cofactor-poor, standard American ultra-processed food does not help this work. Increased mitochondrial oxidation without antioxidants to help buffer is a problem. And again, these antioxidants like cofactors come from our food. Sedentary behavior will potentially drive more stress because you're not moving, you're not taking up the sugar. So that's also using up cofactors. And so this is a big piece of the discussion. Let's take the prototypical cofactor iron, right? Iron has to be absorbed after it's taken in. So you got to eat it, absorb it, transfer it systemically in the blood. It has to bind to a receptor, and that has to be used by the enzyme. Right? So there's a lot of places there things could go sideways by single nucleotide polymorphisms. You could potentially have a defect in transferrin. You could potentially have a defect in hepcidin. You could potentially have a defect in how the ferritin cage stores them. And I think this is a super interesting aside. Iron, we always talk about iron in the sense of inflammation, right? So restless leg syndrome, we know happens when iron is low, ferritin levels low, but iron also is high as an acute phase reactant. Anytime somebody has an autoimmune disease, a significant flare of systemic inflammation, their ferritin goes up. The reason being is because iron is super important for viruses and bacteria to replicate. So the body knows, as it always does, what to do when something goes sideways with infection. So it takes all the iron, puts it into ferritin cages, and stores it until the pathogen is dealt with. So it sort of puts us in that hibernation mode. And I think about this all the time with infection, right? Reverse T3. You're getting sick. You start to put your thyroid hormone into a reverse T3 state so it's not active, so you can help your body fight through whatever infection you're going through. You're not wasting that metabolic energy on thyroid function, right? Same thing with infection fighting. You're taking all the iron out of the system. You're sort of somewhat hampering yourself purposefully to make sure the virus and the bacteria don't have access to that. So that's a super cool thing the body does. So iron is necessary in a lot of functions of the body. And it's important to know cofactors and where the possibilities are that they don't function the way they need to. In asthma specifically, zinc is a big player because zinc's involved with fast cell turnover, and there are fast cells in the body, right? So the big ones are your gut, your immune system, and your skin. But your lung turns over pretty quickly too, and inadequate amounts of zinc makes it hard for your lungs to turn over. The prototypical disease is acrodermatitis enteropathica. If you have a zinc deficiency state from that disorder, you are unable to have adequate immune function, you have chronic diarrhea, you get an acro rash from the skin, and it's that story of, oh, interesting, this is how zinc comes to play. So we know zinc is important in preventing infections and a lot of things related. So you want adequate zinc stores to make sure your child doesn't get sick and have issues related to rapid cell turnover. And again, There could be polymorphisms here of how you absorb the zinc, how you consume the zinc, how you transfer the zinc. So we want to make sure we're getting sufficient volumes through our food and then potentially test it and study it in the patient through RBC zinc levels, iron studies, as we talked before, TIBC, total iron, ferritin, transferrin, vitamin D. There's so many different micronutrients and cofactors we need to test to look at that are beneficial in the outcome. For me, it's all about sufficiency. We want to test them all to see if we can get any that are out of whack. We'll put them in primarily through food first, secondary and supplementation form if need be. What about mental and physical stress? Shifting gears again, nature versus nurture. Phenomenal work by Dr. Moshe Schiff. Again, one of the great epigeneticists of our era. He said with rats, what happens if we cross-foster rats that were born to mothers who were tendency to high licking groom, which means they're very nurturing, took those babies that were born to the high licking grooming mothers and cross-fostered them to mothers who are tendency for low licking grooming or low nurturing. And then the other way around, the low licking grooming pups went to the high licking grooming mother. So this is the classical nature versus nurture experiment. If it's the genes, the high licking grooming pup will do fine with the low licking grooming mother. If it's the nurturing, the high licking grooming pup and low licking grooming mother will do worse. And that's exactly what happened. The low licking and grooming pup went to high licking grooming mother, did very well. Lower stress response later, when those animals showed to the same stress response, the glucocorticoid receptors were upregulated. So now we have another piece of the Darwinian story. It's not just self-selection over time that we die out and we have gene alterations. It's Jean-Baptiste Lamarck's theory. In your lifetime, stressors will change your epigenetics that then lead to this global picture of how your body responds. And we know very clearly now from the data that adverse childhood events will make asthma worse. No question, right? Chronic toxic stress, not a good thing. So we want to limit this in kids. We want to find out if they're in stressful environments. We want to help unwind that. So that's the social determinants of need, the social determinants of health, that we want to be involved in their lives to help them have better outcomes so that their stress doesn't change them epigenetically, so they go on then to have immunologic problems that lead to more disease. And we start seeing kids come in frequently with recurrent problems. We want to, at that point, say, okay, there's something here. We get our social work team, our care managers to come in and say, can we unwind something here? Is there anything we can pull a lever on family-wise or stress-wise, something happened in the past, therapy, to help this get better, right? And that's whole child medicine. That's why we really want to see this stuff. So for me, that's a big, big player, right? And the other thing that's super important we know about stress is that stress has an effect on cortisol. Acute stress actually upregulates cortisol, but then downregulates inflammation. Because under acute stress, you just want to get away from the bull. You don't care about digesting. You don't care about fighting infection. You don't care about any of that. You need to get away from the bull. So blood goes to your brain, blood goes to your muscles, blood goes to your heart, and you run and you get away, and then everything returns to normal. Chronic stress, that's a different ball of wax. Somebody with chronic stress is going to have something else happen. They're going to get cortisol resistance, right? And so in that case, they'll have actually NF-kappa B from the nucleus of the cells turned on, and then it just releases into the system. And NF-kappa B, nuclear factor kappa B, from chronic stress will cause chronic inflammation, okay? That's a big one. So adverse childhood event, chronic stress of the home, chronic stress of all this stuff increases inflammation in the body. It is not good. So the levers to pull on there again, social determinants of health. Get care managers in there. Get your team involved in helping these kids get through it. Meditation, right? Big one. Prayer, breath work, 4-7-8, or the relaxing breath. All this stuff helps parasympathetic autonomic function. You know, for me, polyvagal theory may come in here with Dr. Stephen Porges' work. Maybe we need to start going a little deeper into these places to help these kids stop the triggers of life. We know stress reduction is anti-inflammatory. We know it increases pulmonary function. We know it increases GI motility, which will help with inflammation again, which then helps with pulmonary function. Helps with gastric acid production, which helps break down proteins, which will help with decrease large protein molecules that get into the gut, cause leaky gut inflammation, which then leads to pulmonary problems, right? So all this stuff fits together. Increased mucus production, traps organisms, beneficial in the gut, right? We want that to happen. Decrease intestinal permeability, again, beneficial. Decreased total body systemic inflammation, primarily through the reduction of NF-kappa B. Big, big, big stuff. So again, levers to pull on. Upstream triggers of stress. We want to work on those, right? So we can decrease oxidative stress in the body. We can decrease inflammatory stress in the body, decrease all these things. So avoidance of toxins that are triggering oxidative stress, hypoxia. We want to avoid chemicals. We want to avoid emotional stress. We want to avoid food stress. I mean, again, stress has a million layers, and we want to avoid them all because in the end, that reduces the stress burden on the body. And that in turn reduces oxidative damage, mitochondrial damage, and the problems of our cells in our lungs and everywhere else. Levers to pull on from an a vitamin and micronutrient perspective here, polyphenols, right, in foods help with reactive oxygen species, vitamin A, vitamin C, vitamin E, all these antioxidants, right? Glutathione, N-acetylcysteine. These are what we would call the molecules that are involved in the downregulation of this intrinsic response to external exposome events that are problematical for us. Big, big, big deal. Okay? So we know toxins are bad. We want to avoid them. The dose makes the poison, right? So if it's early on in life, the dose doesn't have to be as high. As they get older, dose can be a little higher and you can tolerate it. Either way, you need to know what your body can handle, right? And so in general, I just say avoid it all, right? That's huge. Problems we have now, we know that if you check cord blood of humans, they have a lot of toxins in their bloodstream. 10 American study by Environmental Working Group showed this. So we have a problem. Microplastics are getting into our foods now. We have no idea what these things are doing, but it's problematical. We know that a lot of these chemicals like BPA are endocrine disruptors. What are they doing? Well, we know they're Th2 polarizing. What is Th2 again? Going back to the beginning, Th2 high is two of the main endotypes of asthma. So if you're pushing your Th2 system via plastics and endocrine disrupting chemicals like phthalates and BPA, you're in trouble. It's going in the wrong direction. Air pollution. We know this is a huge problem. PM 2.5, massive, massive problem for the lungs. When there's fires, when there's chemical exposures, kids' asthma is worse. We don't need case control studies for this. We know. We just need to avoid them. And then, interesting enough, there is epigenetic events occurring here. So we've seen now PM 2.5, nitric oxide, nitrosamine type products in the air can trigger an epigenetic event with MAC5AC, right? This is a gene epigenetically that can be turned on that increases mucus production pathologically, so much so that it's actually driving dysfunction in the body, right? And so we get worsened asthma there with problems related to that. So that's not a good thing. And then, we want to sort of control this whole environment. So if we think PM 2.5 is dysfunctional towards the MAC5AC gene, then that's something we want to avoid, right? So this is a big piece of this, is actually knowing all the levers. And the simple piece is we don't need to know the details. Science is super cool. Ultimately, it's just avoiding the toxins, avoiding the triggers, right? Sleep, big one. Immune system dysfunction is highly certain with sleep deprivation that's chronic. There is an upregulation of Th2, downregulation of Th1, downregulation of natural killer cell and innate immune function, increased problems related to inflammatory mediators like IL-1, IL-6, CRP, TNF-alpha, all of this stuff that we see that we've sort of been talking about throughout this entire talk, upregulated with sleep problems. So we're looking in kids for mouth breathing, difficulty with tonsillitis or adenoids that are oversized, so hypertrophic adenoids, big deal, right? So we're looking for those kids. We're looking for restless leg syndrome. We're looking for kids who are all over the bed at night. We're looking for low iron status. So we're trying to find all of these potential problems. Cow milk protein intolerance. If they're getting sick all the time, they're not sleeping well, right? All of this stuff is the whole child. Diet and asthma, getting back to this just a little bit more. One really good study that looked at this, Dr. Julia wrote an entire paper on this. Some of the takeaways were maternal food antigen and allergen avoidance during pregnancy or breastfeeding is not recommended. We sort of touched on that. LEAP study, super important. Increased diversity of food antigen exposure during the first 12 months of life reduces asthma risk. 4 to 12 months, big window. Eat those foods, get them all in. Everything but honey, raw meat, and raw fish between 4 and 12 months. Eggs, peanut butter, you got it. Probiotics. Certain kinds of probiotics can certainly help reduce the risk of asthma and allergy, right? So in newborns, there's this new probiotic called Avivo, B. infantis specific, that has all, I want to say it was 20 enzymes, the genes for the enzymes to help break down all the human milk oligosaccharides. Fascinating, good product, really like it. Other than that, I use HMF Neuro. There's other products that you can use if you like it, but looking for a mixed, higher colony count of Bifidobacter lactobacillus primarily, right? Consult your primary physician or your group to discuss what types you like. Working hard on reducing the diet that drives metabolic syndrome and obesity, and that's primarily ultra-processed foods, sugared beverages, things of that nature. High-fat meals of the saturated fat type are triggering to inflammation of the immune system, so I don't recommend them on their own. A piece of steak with vegetables and fruits, probably totally fine. A piece of steak with French fries, not the best idea, especially if it's a non-grass-fed, corn-fed animal. Omega-6 full, omega-3 poor, not the best idea. I'm not a huge fan of dairy. I think at this point in my life, I think dairy at the age of 1 is the end. I don't think there's a really great place for it after that. Just my opinion. I mean, we can go back and forth on this. Walter Willett's big paper sort of came out equivocal. There's a lot of downsides, some upsides in my clinic, a lot of downside. Constipation, lots of cow milk protein intolerance, like I said, lots of mucus production. I just think it's a problem. So in my clinic, I tend to try and avoid giving dairy to kids. I love fiber. From 4 months on, foods with fiber, never go wrong. Diversity of fibers are great. All kinds of different foods, berries, beans, vegetables, grains that are high quality, oats. I like buckwheat, all that stuff. And then diverse color, right? Let's get as much color as we can into the diet. The polyphenols, the rich colors are great. They make a big difference. The richer the color, the more antioxidant benefits they are. I like organic. I like homegrown. I like all of that stuff. Omega-3 fatty acids, we need to put a little bit of time into this, right? So statistically, we are consuming way too many omega-6 fatty acids, which are technically pro-inflammatory. This is not a bad thing. This is a good thing, unless you have too much, right? Everything is in the body for a reason. There's balance. The ratio, Dr. Weil tends to say, is usually 3-to-1, which is what we tend to find in the fish. Right now, we're somewhere in the tune of 20-to-31 based on your standard American diet profile. Omega-3 fats, where they break down, we primarily use them in the DHA or EPA form when they're going through their enzymatic reactions to go into cells in the brain and other places of the body for function. And then the special pro-resolving lipid mediators that come out of there, like resolvins, protectins, maricins, those are all heavily involved in decreasing inflammation. Love fish oil. Highly encourage people to eat small, oily fish, mackerel, salmon, sardines, just good stuff. When I think about direct herbs for Th2 excess patients, the Th2 high phenotype, I think of Perilla frutescens. It decreases Th2 polarization and inflammation. And oh, by the way, it does help with candidal overgrowth. Quercetin, love it, blocks phosphodiesterase 4 activity, relaxes smooth muscles. Very, very useful in asthma and allergies. Astragalus modulates Th2 activity, also an immune enhancer. And acetylcysteine, a glutathione promoter. Again, it's the rate-limiting step in the production of glutathione, which helps decrease xenobiotic and foreign chemicals from taking advantage of the body. For the not Th2 type, sort of that, obesity metabolic phenotype, I like berberine. Microbiome modulation inhibits NF-kappa B and IL-6. I think berberine is turning out to be one of the great herbs for immune modulation. I love zinc, promotes epithelial cell production, immune viral activity, and again, fast cell turnover. Turmeric, I think of that in specifically blocking NF-kappa B and dramatic inflammation. I love phytonutrients for antioxidant help, so reducing oxidant mitochondrial damage. So if your favorite phytonutrient supplement, like OPCs, right? That's a good one. OPCs are really great. There's a bunch of different brands out there. I love OPCs in this case. NAC, again, glutathione promoter, and then actual liposomal glutathione in this case would be a reasonable opportunity or use state for preventing inflammation overload, right? And then I'm remiss to not spend a little bit more time on curcumin. I think it's one of those really powerful herbs like berberine that has just this pleiotropic effect on downregulating inflammation. But oh, by the way, it also helps with Treg function. So it really pushes on a lot of the levers we've talked about immunologically that are super beneficial. And then let's go through a case. So the prototypical case is one child I saw years ago. OP is a 6-year-old Caucasian young man with a history of milk and soy protein intolerance as an infant, tolerated ready-to-feed and powder alimentum, right? So we know milk protein tolerance, did well on the hydrolyzed formula, so cause and effect likely really helped him with the inflammation. His symptoms included colic, eczema, green stools with microscopic blood, pre-alimentum. 12 months of age, he restarted dairy as milk and cheese, and eczema, wheezing, recurrent otitis media, micronutrient deficiencies, and chronic rhinitis were all established at that time. He had PE tubes put in his ears at 18 months, and they refused elimination diet, so he persisted in this trouble. He was started on budesonide, 0.5 milligrams twice a day, albuterol, cetirizine, 2.5 milligrams daily, and triamcinolone ointment, BID, or twice a day for skin. Not my favorite answer, but patient wasn't willing to go back on the diet, so we sort of got stuck with old allopathic medicine. 24 months of age, serum IgE level was 36, which was normal. All environmental allergens were negative as tested. Vitamin D was low at 16, ferritin was low at 13, zinc was low, RBC type at 8.8. So we have micronutrient insufficiency driving a lot of immunologic dysfunction. Supplements were started, but we did find some serum IgG intolerance elevations for egg, casein, gluten, banana, and beef. Elimination at this time of the diet trial was successful, and they followed through with it. Symptoms improved for a year, and then unfortunately the parents restarted the foods, and it went back into trouble. Intermittent issues at that point for years, when the diet supplement waxed and waned. They would be on and off it. At age 5, found him in clinic again, this time with chief complaint of swollen tonsils and recurrent symptoms. That time we rediscussed the whole pathology, immunology, went back, This time, the family decided to stick to the plan: dairy, egg, gluten avoidance, AI-style diet, lots of fiber supplements, and complete recovery, symptom-free for over a year. So that would be what I would call the prototypical case. Looking for the antecedent triggers you can lever pull on to help decrease the need for drug. Sometimes we have to do drug. We do it. But preferentially, I'd like to see us get to a point where we can stick to these patterns for longer so we don't end up in situations where we need the meds. Case 2. DM is a 12-year-old Caucasian male who presented for the first time at age 8 years with moderate persistent asthma and allergic rhinitis. And so this child had a history of MPI, milk protein intolerance, soy protein intolerance, and also corn protein intolerance. So casein protein intolerance, soy, and corn protein intolerance as an infant. He had no atopic dermatitis or gastroesophageal reflux, just wheezing that occurred at 18 months of age when his respiratory lower tract infection hit. Over the subsequent period of that winter, he had 3 severe asthmatic flares that required steroids. And this was something of a pattern for a few years. This was at an outlying clinic. This was not at our clinic. And then he had relatively mild disease for the summer in between that. So winters were really rough, sometimes admitted 2 to 3 times, and then summers were relatively mild. So clearly a huge trigger from infectious etiologies. Family history noted that his father had allergic disease. His father had atopic dermatitis, gastroesophageal reflux disease, and asthma. Environment history: he had a dog in his house, carpeting in his bedroom, as well as many stuffed animals on his bed that he played with. There are not any noted social or spiritual concerns with the family. There were no local toxic exposures. A thorough environmental history could not elicit any intermittent cause for the flare. So really we're pinning this on, this is likely related to the infections and potentially something else. His diet was great: whole foods and vegetarian, little to no ultra-processed foods. His meds, when I came to see him the first time, he had Q-bar 80 milligrams twice a day with a spacer, albuterol as needed, cetirizine 5 milligrams daily, and Pataday for eyes, 1 drop each eye daily as needed. Laboratory results noted normal pulmonary function testing in the mid-summertime when I first saw him, when he's asymptomatic. Serum total IgE was high at 499. Allergic serum IgE antibody to cat dander and 3 dust mites tested were all high. All the specific IgE testing was negative. Skin testing was positive for dog, cat, and dust. Vitamin D level was 35, not terribly low, but not in the normal range. Red blood cell zinc was low normal at 10.3. Serum IgE testing was positive for gluten, egg yolk, and egg white, and soybean, and he did not have any serum IgE food testing because he had no immediate type sensitivity reaction warranting such. So he was placed on an elimination diet, main offending foods: dairy, egg, and gluten. He rotated legumes to limit their exposure. Herbal medicine was started with stinging nettles, quercetin, and bromelain. He had a probiotic of 40 billion units daily, 1 gram of marine fish oil daily, zinc picolinate, 30 milligrams every other day, magnesium citrate, 100 milligrams twice daily. He was also counseled to get 20 minutes of direct sunlight daily without sunscreen. Over the subsequent 12 months, he was able to go an entire year without a serious asthma flare, stayed on his ICS, his inhaled controller steroid, but no major flares, no admissions to the hospital. Family was reluctant to remove the dog from his home, even though it was counseled that that might be best. So we discussed starting sublingual immune therapy, which we did with Allergy Choices. Over the next 12 months, he was able to wean off all of his inhaled steroids and never required another admission to the hospital, nor another ER visit. By year 2, he had added back eggs and no problems. No increase in issues of his asthma, no increase in issues of any kind. He did remain off gluten and dairy until our last visit and has done well. To this day, he has remained off of ICS and has had no major concerns. So I think those 2 cases are emblematic of 2 ways to approach a patient based on the upstream analysis of the etiology of disease. So let's sort of do the to-do. What do we want to do with kids, right? For me, food first mentality. Consume 10 or more servings of fresh whole food, specifically vegetables and fruits daily. Focus on colorful, antioxidant-rich types of peppers, carrots, and the brassica family. Rotate foods constantly and eat seasonally where possible. Drink lots and lots of fresh, clean water daily. Eat high-quality liver once a week, if possible, for minerals and vitamins and methyl donors if you know you have good quality liver. Avoid all processed foods. Aim for 40 or more grams of fiber a day. Beans and berries are the best and great sources of fiber. Eat salmon, mackerel, sardines, and trout frequently to take fish oil, right? Avoid foods that are known sensitivities for you. Try elimination diets. Always highly recommended. Control your local environment. Reduce exposure to all aerosolized products, synthetic types, anything burned, PM 2.5 particulate matter. Try and really keep your aerosolized environment clean, right? Avoid known triggers: animals, dust, cockroach, pollens. Use HEPA filters where you can. HEPA vacuums to clean. Encase beds, encase pillows, wash sheets, clothing frequently if you have dust mite sensitivities. Keep indoor humidity below 50% so you don't promote the growth of dust mite. I highly encourage cofactor testing, blood levels for zinc RBC, copper RBC, magnesium RBC, ferritin, vitamin D, omega-3 index, uric acid, fasting insulin, IgE total and expanded tests if elevated serum total, right? Food intolerance panels, consider Genova or Cyrex. Work on mental stress and identify adverse childhood events. I highly encourage you, if you have a team involved that can do adverse childhood event analysis therapy, put them in play. Care managers. One of the things we have in office that is invaluable. Help the kids learn to pray, meditate, use apps like Headspace, Calm, Insight Timer to help them improve their sense of self and their well-being. Daily exercise, fantastic. Never much of a problem with kids, but nowadays with screens, that is becoming a problem. So encourage daily exercise. Never stop your meds until you think you are symptom-free enough to do so with guidance of your provider. Continue your inhaled corticosteroid for sure. That's the most important one. Add herbals as desired, right? Quercetin, bromelain, stinging nettles, berberine, chamomile, turmeric, all these as discussed. These are good products to look into to help decrease inflammation, modulate the microbiome, decrease the basophils and eosinophils and all these immune cells from activating and doing their work on us. Highly consider sublingual immune therapy with groups like Allergy Choices, where you could actually put sublingual antigen under the tongue to retrain the tolerance of the immune system to not react. I love polyphenol blends again, OPCs. They may be useful for helping us deal with rust of oxidation that occurs within our bodies. And ultimately, really spend time thinking about other ways technologically to go through this. Propeller Health sells a device that GPS's location of where the asthma inhalers are being used, so you might glean insight into this, right? That's super important. You know, the bottom-up approach. Everything is learned from the bottom. Help your patients, help you, help get everybody moving in the right direction for the best health. So for me, ultimately, why do I care about this? I care because you can go upstream. We can look at the epigenetics. We can look at what's modifying. Lamarck was right. It's not just changing Darwinianly. We're changing real time all the time, and that is the hope story that is understanding of the immunology of asthma. There are a lot of levers to pull on. Primarily, I focus heavily on nutrition, cofactors, stress, exercise, and toxin avoidance. And then I'll add in sleep as well. Those are the big levers to pull on. I hope you pull on them. I hope you have a great day. Thanks for your time.